So with the permission of the chair, I'd like to invite Dr.Rakesh Gupta to speak on diagnostics and management challenges for the next 15 minutes. And Dr. Gupta is currently chairman of the coordination committee of WCCPCI 2016, director and chief cardiologist of Echo and Color Doppler Center at JROP Institute of Echocardiography, Ultrasound and Vascular Doppler, New Delhi, senior consultant cardiologist at Max Super Specialty Hospital as well. Ladies and gentlemen, this keynote address will follow with brief comments from the chair. Thank you.
Respected Chairperson, good morning friends, ladies and gentlemen. Let me talk in next 10 to 15 minutes what are the challenges in diagnosis and treatment which we face in day to day, and that's too in 2016. None of my slides belongs to less than 2016. That's what I want to say at this moment is. Well, the most important thing is the optimal management of asymptomatic severe aortic stenosis still remain controversial even if we are in 2016. Considering the increase in incidence in elderly patients, improved surgical outcomes, and with the introduction of TAVR, many things have changed. We are able to take up those people who were not able to undergo surgery, that's in high-risk cases. And that's where we started looking at optimal management strategies for these asymptomatic subjects. Incidence of sudden death in asymptomatic reasons varies anything from 0.25 to 1.7% per year, and with differences which are related to study designs, patient's background, and many more factors. And one important point in 2016 we should accept is, except for a very severe aortic stenosis, the sudden death in severe aortic stenosis related cardiac death without preceding symptoms is very uncommon if we have a watchful waiting strategy which we adopt in this subset of severe asymptomatic aortic stenosis. Very often this question is being asked, what is the difference between severe versus very severe aortic stenosis? Whether symptomatic or asymptomatic severe aortic stenosis, can we differentiate the classes of asymptomatic severe aortic stenosis? And similarly, can we differentiate the classes of symptomatic severe aortic stenosis? And obviously today is an era where we are not talking of echocardiography, we are talking of imaging modalities for diagnosis and for therapeutic challenges which we are facing in today's practice. So we need to have more imaging modalities, as my predecessor, Dr. Satish Govind, was showing, looking at the echo in TAVR. Similarly, we are talking of imaging modalities in aortic stenosis. Well, if I look at severity of aortic stenosis, we need to consider at least 3 parameters. In today's scenario, looking at a stroke volume indexed, mean pressure gradient, and aortic valve area measurement by continuity equations. And if I have to say somebody is severe, apart from these 3 parameters, we have to have a peak velocity which is more than 4 meters per second. But one important point is we should look at all 6 windows of echoes before we say that his peak velocity is less than 4 meters per second. And if you talk of a very severe, the varying opinions present ranging from 5 to 5.5 meters per second. And recently one publication in ESC, highlight of valves, which say anything more than 4.5 is considered as very severe. And if I label at all this, hemodynamic severe aortic stenosis is peak velocity more than 4, mean velocity more than 40 millimeters of mercury, and aortic valve area by continuity equation less than 1 centimeter square or indexed less than 1.6 centimeter square. As I said in previous slide, we should look at all modalities, whether it's 2 dimensions echocardiography. We have to put in the colors and then do a quantifications. And 2D stain has started putting a lot of emphasis looking at the subclinical dysfunction in aortic stenosis, LV function, and take up the modalities of a cardiac CT and MRI in a final conclusion for a diagnosis. Idea is why we want to involve all these modalities. We want to pick up those people who have a substantial changes in their LV functions before they become symptomatic. And that's what I wanted to say is, how do we say a patient is symptomatic versus asymptomatic? We need to consider many comorbid conditions in our country. We never look at them. These are the couple of them, and many more are present, and we have to look at a patient in a holistic way. And once we rule out all these kind of problems, we should always look at these two modalities. One is exercise testing, and second is looking at the BNP levels. This is one chart published in JACC 2016, looking at the role of exercising testing in patient of asymptomatic severe aortic stenosis with all the parameters which I said a couple of minutes back. Is a symptom related, producing a syncope, dyspnea or angina? This is a class 1 indications for asymptomatic, should undergo surgery. And if there's a decrease in a blood pressure of less than 20 millimeters of mercury, then this is one patient we should identify, which he says that asymptomatic, but is symptomatic. Similarly, we look at a natriuretic BNP levels. If you find a BNP level which is sustainedly elevated, and especially after exercise, these are the people who fall in class 2B indication for treatments. Today, we divide these people of asymptomatic severe aortic stenosis into 4 classes. We look at the peak velocity, we look at the peak mean gradients, we look at aortic valve area, whole or indexed, and a stroke volume index. And we call them as normal flow, means the stroke index is more than 35 cc per meter square, and high gradient, they classify into the high gradients. We say a normal flow is maintained, the gradients have become less. And one entity which makes lots of difference is a low flow, low gradient aortic stenosis, which we call them as paradoxical aortic stenosis, where the flow is less, but aortic valve area, whether whole or indexed, is much less. And this is one class of people we come across many times. And the simple reason behind it, person develop a significant left ventricular hypertrophy. So driving force is more, but the volume of which is ejected out is much less. And these people, they are a worst stage of any incidence and a poor prognosis. And this is one where LV function has started failing down, LV function goes down. And what we have been doing for the last many years, we subject these people to a dobutamine echocardiography to look at increased gradient and valve area to say that these people should be taken up for surgery. This is one chart which talks of all these kind of things, people. Indications 1A, 1B. Let's look at these things again in a little more organized manner. We have a high gradients, we have normal flow, low gradients, low flow, low gradients. And if you look at these high gradients, there is no doubt that these people should go for AVR or interventions. If you have a normal flow, low gradients, measurement verification, and there is no specific indication, we should be taken up for surgery. And obviously, I talked about low flow, low gradient aortic stenosis, and these people, they are at class 2 indications. Multimodality imaging, we look at these people by an echocardiography. We go ahead and do the risk stratification for a selection of AVR, confirm severe aortic stenosis and risk stratification, and confirm severe stenosis whether the person is in symptomatic or asymptomatic by utilizing multimodality imaging treatment. And how do we do it? It'll come down a couple of seconds later. But there's certain parameters which helps to make a risk stratifications. If my velocity of aortic stenosis is more than 5 or 5.5 meters per second, I'm at very high risk for us MACE. If I've got a low flow and low area with a normal stress test and the so-called paradoxical, I'm at high risk. Normal BNP levels, they are associated poor, and if these BNP levels, they becomes very high after stress, they still indicate a poor prognosis. CT scan and MRI, they help a lot. The calcium score more than 1200 auxiliary units in females and 2000 auxiliary units in males. And similarly, LVOT diameter, which we take in help of CT scan, If aortic valve area with this method is less than 1.2 centimeter square, it's of good utility. Well, this is one modality which makes a lot of difference in MRI. In patient with aortic stenosis, we look at anatomy as well as function. And if we look at the myocardial fibrosis by late gadolinium enhanced scan, it means these people are already having a decreased LV systolic function. In conclusion, friends, I'll say every patient of aortic stenosis has to have a clinical background, age and comorbidity, and based on all these parameters and natural history, a decision should be made, which should be patient to patient wise. And we should spend time with a patient of aortic stenosis when we encounter. Look at the echo parameters, at least 5 of them, and still in doubt, utilize other imaging modalities like CT and MRI. And this is one just published in European Society of Cardiology highlights. Asymptomatic, very severe aortic stenosis patient, more than 4.5, they are associated with better survival when they undergo surgery rather than to wait for symptomatology. In conclusion, finally, I say, if you have a patient who's asymptomatic with more than 4 meters of a flow velocity, utilizing all 6 windows for evaluation, always put the people, if they talk asymptomatology, always put these people on a treadmill. Look at those 2 parameters which I said. After excluding all the comorbid condition. And if you happen to find a person more than 4.5 meters of a velocity, subject them to surgery, whether they are symptomatic or asymptomatic. Thank you very much for your patience here.
Rakesh, please join us here. I think this was a very brilliant session and a very important session. Every one of us come across all the patients of aortic stenosis as the elderly population is going in India. We have with us a giant of interventional cardiology, and we have a surgeon sitting next to us. I'd like to just have their comment before we go further. Samin?
Yeah. No, I think both echo and presentation of the collect patient have been very well highlighted. Just to add on to that, the trials of the TAVI for high risk, extreme risk and intermediate risk have shown the advantage or superiority of the TAVI now over the surgery. So this is has shown in every way. In the past, there was a situation that maybe the TAVI valve has a higher stroke rate, but the newer devices, that's no longer true. Now, big question comes in the low risk, and many of these patients are young age, and they're asymptomatic. And I think the asymptomatic issue is very important. So just to highlight the low risk trial, which are ongoing at present, which both SAPIEN as well as the core valve, which is the Evolute, we are randomizing, making the patient asymptomatic if it is more than 5 meters per second. If your velocity is more than 5, patient can be enrolled, even they are asymptomatic. Now, if they are between 4 and 5, asymptomatic, then you need to do a stress test, as mentioned, that if you have a hypotension or resting depression, during stress test, then they will qualify. So clearly that this field is evolving, and particularly more so for the TAVI, and more so is the durability question about the durability of the TAVI valve, which we think that it will be similar to the bioprosthetic aortic valve, but we don't have the long-term data of beyond 6-7 years.
Thank you, Sameer. I think it was a brilliant presentation by both the speakers, Govind and Rakesh. Govind pointed out very, very important way of TAVI evaluation, and he mentioned very clearly how we are to evaluate at the annular level, subannular level, supravalvular level, and everything in detail has to be analyzed before we really subject a patient for TAVI to reduce the morbidity and mortality. And the Rakesh was very specific. He brought all the points of a low gradient, low flow, high flow, low gradient, and he mentioned about the high gradient also, and how to choose these patients. If required, who should be subjected for DSE, dobutamine stress test. I think our criteria should be a multimodality imaging, is also highlighted by Rakesh. And I have next to me sitting a guy who want to talk on CT. You want to say something on CT versus echo. Rakesh also pointed out another issue, that all the patients should be screened, not only echo, but he also mentioned a word about BNP, with BNP and without BNP. This is also a very important point which he has raised. We'd like to have your opinion, sir.
I would like to thank both the expert speakers here on giving the details of how echo is used to assess both the severity of aortic valve stenosis as well as for assessment for suitability for TAVI. And as we know, echo is the gold standard for assessment of aortic stenosis, for assessment of ventricular function, to assess the pressures in the ventricles, and to assess for any presence of valvular regurgitations, etc. CT, in my practice in UK, we are using CT most of the time for evaluation and assessment of aortic annular size and for peripheral access evaluation as well. And I would like to know from the expert panel here working in India as to how they are using CT in this context for TAVI assessment.
Rakesh, would you like to comment on this?
Certainly, like we are using a lot of CT for a TAVI assessment, as Dr. Satish has categorically pointed out. What we look by echocardiography may not match with the CT data. Obviously, if you are looking for annulus diameter, we spend a lot of time with the CT scan, but echo is a collaborative modality while doing a TAVI. That's what is exactly happening.
Okay.
And Satish has got a lot of experience. He has been instrumental in doing almost 22 till date. Like latest figure about a few minutes back, which I got it. Yeah. And he has done almost 22 in Bangalore till now. We'll be able to highlight more on this.
Thank you, Rakesh. I think Satish has given a very broad view and a very beautiful way of explaining. He did the same thing in Madurai also, and I heard him. It was very, very brainstorming and thought-provoking as to how we should go. And Samin just mentioned that we are doing a lot of TAVI in young patients now, and we are trying to have new criteria. Opi, you want to say something here?
Well, everything has been said. I just want to add a little thing to Dr. Rakesh Gupta. In asymptomatic aortic stenosis, any level of pulmonary arterial hypertension or atrial fibrillation disqualify the patient to be called asymptomatic. So please, that's just the addition I want to make to Dr. Gupta.
Okay.
Thank you.
Thank you very much. I think let's give a big hand to all the speakers, and I'll request the chairpersons to join me to give a token of appreciation to both the learned speakers, Govind and Rakesh. They did wonderful job. Opi, Samin, please come forward. Naveen can join us in front, a little exercise, otherwise you'll be sitting all the time here.